Alrighty, so part 2 of chapter 9 lecture. We're going to go over vascular access devices and sites. So I'm sure we all know what an IV is. Basically, this is just a catheter or tubing inserted into a peripheral vein, which would be veins in basically any veins in your arms, not part of your torso. But I have seen them put IVs in the chest if patients like really difficult before. So basically, IVs are used to administer fluids and medications. Before a nurse flushes saline through the IV, they can draw blood off of the site. Not all nurses will do this, some will, to save the patient a poke. But once the saline has been flushed through that line, they can no longer draw blood off of an IV site. And this is because there's basically like little valves in the IV that prevent the backflow of IV fluids. A lot of times this can cause hemolysis if they try to draw blood off of it, but I'm not going to get into that much depth. But so just know that IVs are designed to administer fluids and medications. With that being said, you are going to want to avoid drawing blood from an arm containing an IV if possible. That's because the fluid or medication, whatever they're pushing through the IV into the body, into the veins, can contaminate your blood sample and give erroneous results after testing. If, however, a patient has IVs in both arms, or say they have a mastectomy on one side, they have had a mastectomy on one side and have the IV in the other side, because you're not supposed to, puncture the skin on the mastectomy side, you may have to draw from an arm with an IV in it. If that is the case, your best option is going to draw below the IV. If you draw above the IV, guaranteed 100%, it's going to be contaminated with that whatever's flowing through the IV. If say the IV is in their hand, so you have to draw above the IV, there's no option to draw below it. What you can do is locate a nurse and have the nurse shut the IV fluids off for five minutes. After 5 minutes, you may come back and draw your blood above the IV site. This gives the IV fluids time to dissipate from the area, so it won't contaminate your specimen. They say 2 to 5 minutes. I usually go 5 minutes just to be safe, because I have drawn a patient before and waited a few minutes, like around 2 minutes, drawn above the IV, and had to go back up later and poke them again because the sample was still contaminated with that fluid that was running through the IV site. So 5 minutes to be safe, I would say. Anything else I want to say about that? There's a really good procedure in your book, Procedure 9.1 on page 281, which talks about performing a venipuncture below an IV site. This procedure tells you to shut the IV off even if you're drawing below the site. At some facilities, they may ask you to do this or require you to do this even if you're drawing below an IV. At our facility, we only require you to shut off the IV if you are drawing above the IV site, or from the same vein that the IV is in. But you really don't want to do that if at all possible. Do not draw from the same vein that the IV is located in, whether above or below. You just kind of want to try to avoid that. Like I said, every situation is a lot different. It might be your only option, but try to avoid it if you can. So, in the venipuncture procedure below an IV, Procedure 9.1, step 1, ask the patient's nurse to turn off the IV for at least 2 minutes prior to collection. As we are not qualified to turn IVs on and off, you have to ask the nurse to do it. Not only that, but if we shut an IV off, it's going to start beeping, and the nurse is going to come in right behind us and turn it back on if they are unaware that we turned it off for the blood draw. Because a lot of times what we'll do is we'll have the nurse shut that IV off, and then we'll go draw another patient or two before we come back. That way we're not just standing in the room wasting time when we could be drawing other patients. And then we'll come back around and draw them after the 5 minutes is up. Go let the nurse know after you've drawn them that they can now turn the IV back on. But anyways, so turning off the IV for 2 minutes, 2 to 5, allows the IV fluids to dissipate. Then you're going to apply the tourniquet distal to the IV site. This avoids disturbing the IV. So distal means what? Further away from the body. So preferably below the IV. Distal would be below. So to not disturb the IV site. I think I wrote something about that. About the IVs above. So if you put the IV above the IV, it can disturb the IV site in that it can collapse the vein. It can move the catheter in the vein, or it's just best to go below. But like I said, sometimes you don't have a choice but to go above. Selective venipuncture site distal to the IV. So venous blood flows up the arm toward the heart. Drawing below an IV affords the best chance of obtaining blood that is free of IV fluid contamination. Perform the venipuncture in a different vein than the one of the IV if possible. So like I said, don't use the same IV, or the same vein, rather. IV fluids can be present below an IV because of backflow and may still be there after the IV is shut off because of poor venous circulation. Ask the nurse to restart the IV after the specimen has been collected. So make sure that you are letting the nurse know after you collect the specimen, because they're going to be kind of pissy if you don't. And they are waiting to start the IV for you to finish, and you just never go and let them know. So keep the nurse in the loop, because their IV flow rates must be precise, and starting or adjusting them is not part of a phlebotomist's scope of practice. Document that the specimen was collected below an IV, indicate the type of fluid in the IV, and identify which arm was used. So at our site, this is not necessary, or at our hospital, we don't document where we collected the blood or what was running through the IV, but there are some hospitals where this is definitely going to be a requirement. So just good practice to remember to do that, even though it's not a requirement at our facility. It just helps the lab personnel. So if the results are off, they know why. They're not questioning what the heck's going on. Okay, so this is a typo. This should be an IV catheter lock. So this is basically a needleless connection device in the form of a stopcock or cap. Saline lock or heparin lock. These are two different versions of it. So basically, an IVC lock provides access to the catheter in the vein for blood draws or medication administration. So this is like where they hook a bag of medication up. They can take it on and take it off. And the reason that I don't know where I was going with that, but it's an open system, so it's not closed off. Like when you open it up, it's open to the environment, open to the atmosphere. So that's why a lot of times it's a heparin lock. So they flush heparin through it to make sure that it doesn't clot off. More commonly now, though, they're using saline, but it always has to be, if it's ever opened, it must be flushed with either saline or heparin every time. So if a nurse draws blood from one of these for you, there must be a discard tube. So when they pull the blood out, so they're going to flush it with saline first, and then they're going to pull back, and because that blood that they just flushed the saline through the device, that first syringe of blood is going to be contaminated with the saline or the heparin that they just flushed the device with. So we must discard that blood, and then the second syringe of blood is going to be the blood that we use for the testing. And then once they're done collecting the blood, they're going to flush the saline or heparin lock again, because if that tubing is stagnant blood is left in that tubing, it can actually clot, and then they won't be able to administer fluids or medication or draw blood from that site again, because it's going to be clotted up. And in that case, basically the IV is bad and they will have to start a new one. So it's actually happened to me before. Yes, I mean, no, it's not our job to draw from these and to ensure that they're flushing them. However, like I said, if you want to be a good, awesome phlebotomist, it's important that you know some of these things and are aware of some of these things. I had a nurse draw from a PICC line, which we're going to talk about what a PICC line is in a little bit here, which is also an open system. So it needed to be flushed with saline before the draw and flushed with saline after the draw. And I noticed that she did not flush the device after the draw. And I mentioned it to her, and she kind of looked at me like I had 3 heads. Like, you're not a nurse. Why would you tell me about that? Later in the day, the nurse manager came down and told me that I would need to sign something stating that I noticed that she did not flush the PICC line with saline after the draw because it clotted, and they had to take it out and reapply or re-put it in. And that's kind of a surgical procedure because they have to fish. We'll talk about what PICC lines are in a little bit, and I'll bring this back up, but just make sure that they're flushing. Okay, I went off on a tangent again, I'm sorry. Previously active IV sites. So you're not going to want to draw from a previously active IV site, and this is because you don't necessarily know how long ago they removed that IV. There could still be some fluid or medication present in that site that could cause testing error. Your best bet is to draw below a previously active IV site if you notice one, or if the patient's coherent and alert and able to tell you, oh yeah, they took that out 2 days ago. Like, that's from 2 days ago. Okay, then you're okay to draw. You want to wait 24 to 48 hours. But there are some patients that aren't coherent enough to, like, remember, oh yeah, that was in there 2 days ago. So in that situation, your best bet is to draw below a previously active IV site. Okay, so now we're going to get into kind of the more difficult parts of this chapter, I would say. So in arterial, so there's different types of access devices. IVs are one of them. They're obviously the most common. Pretty much everyone that comes into the hospital gets an IV. I would say most everyone gets an IV. They at least run a saline drip through your IV site, if nothing else. But these are some less common devices. An arterial line is a catheter that's placed into an artery. It's usually placed in the radial artery on your arm. It provides accurate and continuous measurements of blood pressure. And you cannot, if you draw from a arm that has an arterial line, you should not use a tourniquet. But honestly, you should not be drawing from a line that has, or an arm that has an arterial line at all. Arterial lines can also be used to collect ABGs. They can be used to administer some medications. And only nurses and specially trained personnel are allowed to draw blood from these devices. Actually, any vascular access device. So try to avoid drawing blood from the side of an arterial line. Okay. So, arterial venous shunts or fistulas, these are easy to spot, but it's kind of a confusing topic, so bear with me on this. I'm going to try to explain it as best as I can. First thing I would like to say, before I explain what they are and potentially confuse you, you will never, under any circumstance, draw from an arm that has a shunt or a fistula. An active shunt or a fistula. Basically what these are is, it's a site for dialysis. So if somebody's kidneys are not functioning properly, it's a site for dialysis treatment. It is their lifeline. We do not want to mess with that arm that has their lifeline for dialysis. So we are never going to do this. And more than most of the time, if a person has a shunt or a fistula, they will tell you, okay, I have a shunt or a fistula on this arm, you can't draw from this arm. Their doctors ingrain it in their heads that they are not to have blood pressures or blood draws from that arm. Nothing is going in that arm except their dialysis treatment. So they will tell you when they come in not to draw from that arm. If they're not coherent enough or with it enough to tell you on their own, you will be able to see it in their arm. It's going to be a big bulge down in their wrist area, or sometimes just above their AC area. You can tell. And if you're unsure and you see a bulge, if you put your finger on it and you feel like a vibrating noise, a vibrating feeling rather, that's indicative of a shunt or a fistula. And if you're not sure still at that point, you're better off to just assume that it is one and go to the other arm than to assume it's not one and poke that arm and it actually be their shunt or fistula arm. So another thing with that is if they are in the hospital and they have a shunt or a fistula, they will either be wearing a sleeve on that arm that says no blood pressures or blood draws on this arm, or they will have a sign posted behind their bed. Same with a patient that has had a mastectomy or any lymph nodes removed. They'll have one of those sleeves. It's going to be a red sleeve or a sign posted behind their bed. So make sure you're checking behind patient beds for signs, because they will also have signs if a person is hard of hearing or if they are blind. They will have signs posted so that you're aware of what's going on. So I always check behind my patient's bed when I walk in for that reason. Okay, so I am going to kind of talk with you about what a shunt or fistula is. So basically, what they do is a doctor will join an artery and a vein to create a larger vessel, and this vessel is able to withstand the needles. So they use really, really big needles for dialysis. And what dialysis is if your kidneys are what filter your blood of toxins and waste and that sort of stuff. If your kidneys are not functioning properly, your body is not able to rid itself of the waste, and you will actually end up getting blood, like sepsis, in your blood, because your blood's not being filtered and freed of all those toxins and wastes and byproducts of your natural body functions. So what dialysis does is it basically takes your blood out of your body, and it runs it through a machine called a dialyzer that basically works as your kidneys, and it filters out the impurities in your blood and then puts your blood back into your body. And this, depending on how bad your kidney function is, you might have to have this a couple times a week. You might have to have it once a day, and it usually takes like 3 to 4 hours. So, why would they join an artery and a vein then? What does that have to do with anything? So the pressure inside of the vein increases when it's joined with an artery, because obviously arteries have more pressure behind them. So that makes the walls of the vein stronger. The fusion of the two, the artery and the vein, makes the vessel larger, so they can take and give blood more readily. But the main part is that it makes the walls of the vein stronger, and then the stronger walls can handle those needles that are used for hemodialysis without blowing or becoming damaged. So it basically is designed specifically for dialysis in order to withstand the effects of it. I think that's all I want to say about it. So now that you kind of have an idea of like what a shunt or a fistula is used for, if you go, actually I think it's on that. So here's a good picture. There's different kinds of, so I think I explain it better. Okay, so the top picture is a picture of a fistula, a true fistula. Okay, so there's like a little bump. Sometimes the bumps are like huge, it's like takes up their whole wrist. And like I said, sometimes they're above the antecubital area, and you'll actually notice that if they're currently in use, there will be a lot of puncture marks because the needles are puncturing into that shunt or fistula every day or every other day or 3 times a week, whatever, you will see puncture marks. So that's another indication that it's an active shunt or fistula, okay? So this is a graft. These are not used as commonly anymore now that fistulas have been created. So these were used prior to fistulas. It's basically like tubing rather than directly connecting an artery and a vein. There was like a piece of tubing that they would use to connect the artery to the vein. So you can actually see that U shape, if my mouse will move, that U shape that connects an artery to a vein. These don't hold up as well as fistulas do, which is why fistulas are more commonly used now. But you may see this. I've seen one of these in my time. Many of these. Many that are much larger than this, but this is definitely a fistula. So if you see a bump like that, and you can see there's some scarring from where the surgeon opened up the arm in order to connect the artery and the vein. Excuse me. If you see something like that, just go to the other arm. Just avoid it. Like I said, a lot of times if you put your fingers on the fistula, you can feel like a buzzing feeling, like a vibration feeling. That's a good sign it's a fistula, and to go to another arm. Okay. This is another type of device that's usually connected to an IV or an arterial line or a PICC line or a central venous catheter, something like that. It's a separate device, and this is specifically designed for blood collection. It's a closed system, so rather than the IV catheter lock where it's an open system that they have to flush in between so we have to flush it, we have to use a discard tube, and then we draw the blood, and then we have to flush it again because it's an open system, so it enables the blood to clot in that system. This is a closed system. It's really hard to explain without being able to show it to you guys, but this allows the nurse to draw blood without a discard tube. So the catheters, it doesn't need to ever be flushed because it pulls the blood through this system back, and then she's able to draw the blood out of here with a syringe, and then all of this blood that was drawn back is put actually back into the patient's body without ever being open or exposed to the air. So not only does this reduce the chance of infection, as we're not opening that IV up to, or that tubing up to the atmosphere, bacteria, all that stuff. It also prevents needle sticks. We don't have to poke them. It also minimizes waste from line draws. So if a patient has extremely low hemoglobin and can't really afford to lose a 10 cc syringe of blood, this actually puts that 10 cc's right back into their body after we draw what we need for our blood draw. This is a really confusing device. I know. It's much easier to understand it when you see it working in person. But these must be really expensive because I've only seen like 2 of them used before, and they were both in the ICU with patients that had like really low hemoglobin. So I'm thinking that they're a lot more expensive, and that's why we don't see them as often. But I'm really hoping that we can ask a nurse to just at least show you guys one of these on your externship, because they are pretty cool. Okay, central vascular access devices, also called CVADs. There's 3 different types that we're going to go into, but they're known as indwelling lines. They consist of tubing inserted into a main vein or artery, and they are used for the common administering fluids and medication, monitoring blood pressures, and drawing blood. So if you have a patient that is an extremely hard draw, has really bad veins, they might put in a CVAD just to make it easier for drawing blood, administering medications, so that they don't have to start IVs every time. If a patient's in and out of the hospital often, or on chemotherapy, stuff like that, where they have to get IVs frequently, they're probably going to use one of these instead. It makes it much easier to access their blood vessels. So the 3 different types we're going to talk about are central venous catheters, implanted ports, or peripherally inserted central catheters, also known as PICC lines. You're most commonly going to probably see PICC lines. However, I've seen many of all of them, so I do want you to know all 3 of these. Okay. So, none of these are so as a phlebotomist, you will not be able to access any of these devices. You will have to get a nurse to access them for you, and they may require you to try to poke the patient at least once and get blood elsewhere before they access one of these. And that's because if they are running IV fluids through one of these already, they're going to have to stop running the fluids, wait 5 minutes, flush the line, pull the blood, discard the blood, flush the line again, then start the IV fluids again. So it is kind of like it's kind of a process. It's kind of annoying for a lot of nurses to have to do it, but if the patient is an extremely hard draw, we don't want to sit there and poke them 17 times to get blood when we could just pull it off their line. So it's something you is very useful in certain situations. Okay. I'm trying to think of where I want to go from here. Okay, so with each of these are all considered open units. So they're all going to need to be flushed before drawn back with a discard tube and flushed again after the blood draw. So I want you guys to know the steps in drawing from any of these devices, okay? So I'm going to go step by step through them with you, and then we're going to talk about the differences between each of these central venous access devices. So first things first, if you go in and a patient is a hard draw, you poke them, you're not getting blood, and you notice they have one of these devices, go ask their nurse if they will draw from it. They're probably going to ask you if you've tried to poke them. Yes, you have. Couldn't get blood. So the nurse will come in. You're going to want to make sure that they turn the IV fluids off. If there's anything running through it, then you're going to want to make sure that they flush the line with saline or heparin. They're going to pull back to ensure that the sample's not contaminated with any of the fluid or the flush that they used. You're going to want to do a discard tube of at least 5 milliliters. So give them a 5 milliliter syringe if they need it. Most of them will just use the syringe that they flushed the line with. They're going to pull blood back 5 milliliters, 5 to 10, whatever they prefer, at least 5 though. You're going to take that syringe and you're going to throw it in the sharps container. But you're going to throw it so that the plunger is sticking up, because if you put the syringe in plunger down, it's going to hit the bottom and the blood can actually squirt out of the sharps container. So make sure that you're putting it in with the plunger up. Then you're going to give them another syringe and they're going to draw back whatever amount of blood you need. So how are you going to know how much blood you need when they're drawing from this line? Because they're going to ask you, what do you need? How many cc's? So cc is equivalent to a milliliter, okay? And on each of your tubes, it tells you how many milliliters are in each tube. So if you have a 5 milliliter lavender tube that you need and a 5 milliliter coag tube, how many cc's do you need? 10 cc's, okay? So that's how you're going to figure out how much blood you need the nurse to draw, is by looking on your tubes and doing some simple addition to figure out, okay, I need 10 cc's, or however many you need. And then once they draw that, and you are going to, from your syringe, how are we going to get it into our correct tubes? We're going to follow the order of draw, same order of draw. and you're going to use your little transfer device that just screws onto the end of the syringe. So remember when we were talking about our SPS tubes and how they can be used in instead of blood culture bottles in certain situations, and how we're going to have to transfer those into the blood culture bottles. The same way that we're going to transfer the blood from the SPS tube into the syringe, and then from the syringe into the blood culture bottles, is how we're going to transfer from the syringe the nurse draws into our tubing. So that little transfer device we put in our tubing, while we're transferring it into our tubing, we're going to make sure that the nurse is flushing the line again. Some nurses might be total BITCHs to you if you call them out on forgetting a step, but you know what? It's worth it if the patient doesn't have to go through another procedure, like I said. So keep that in mind. So in your book, it tells you that for the discard tube, you're going to need 2 times the dead space for non-coag specimens and 6 times the dead space for coag specimens. But like I said, 5 milliliters is safe for any specimen, coag or not. So if you have a hard time remembering, oh gosh, 2 times the dead space and 6 times the dead space for coags, and oh my gosh, just remember 5 milliliters. 5 milliliters minimum, that's perfect. Okay? Okay, now I'm going to go into depth on each of these different vascular access devices. Okay, so a central venous catheter. This is a line that is inserted into a large vein, typically in the neck. So either your subclavian or your jugular vein. And then it's advanced. So this is it's called a triple lumen. It's got 3 different access sites. So they can run 3 different IV fluids through there, or they can leave one open, run 2 IV fluids, and leave this one open for the blood draws. But it's going to be inserted, it's usually inserted like in the neck, like literally like up here in the neck, but this is showing it more like in the shoulder area. So anywhere in this area, it's going to be inserted into your subclavian or jugular vein in the neck. And then that tubing, there you go. That tubing is going to be advanced down into your, into the superior vena cava, which is just above your right atrium. Oh my gosh, my mouse is so slow, I'm sorry. So your right atrium's right here, and this tubing is going to be inserted right into there. Okay, so it's a really good access device. It's also really good source of infection if it's not kept taken care of well. So that's what your central venous catheter is. I'm going to come back to this slide after we go through each of the 3 so that we can examine the differences between the 3 of them. Okay, so an implanted port, I've most commonly seen ports in like chemo patients or patients that have cancer. This is basically, it's like a small chamber, and it's just underneath your skin in your chest. Excuse me. And it's attached to an indwelling line that is surgically implanted under the skin. So this same thing, it goes right into your superior vena cava, but this device is underneath your skin. So there's less chance of, like with your central venous catheter, see how it's open? It's open to the elements. There's a higher risk of infection with this than there is with this. The problem with this is every time you want to access it, they have to be poked. So it doesn't save the patient pokes. It just makes it easier to access and less of a risk of infection than with a central venous catheter. Hopefully that makes sense. Again, if you guys have any questions, please don't hesitate to ask. So here's 2 different versions. This one it can be accessed in one site. This one has 2 different accesses, so if they're administering 2 different medications at once. And most of the time, patients will prefer that you draw their blood from the port, because a lot of times the reason that they have a port is because they are a tough draw. And it's just easier rather than being poked a million times trying to get blood out of a peripheral vein. They get poked once in their port and it's good to go. So there's less error with port draws than venipunctures. Okay, this is probably more commonly going to be seen in the hospital. It's called a peripherally inserted central catheter, also known as a PICC line. You will definitely hear it called a PICC line more than you will hear it called a peripherally inserted central catheter. But basically what a PICC line is a line inserted into somewhere in the patient's peripheral venous system, so anywhere in the arms. I've never seen a PICC line down by the feet, but in the groin area, I have seen PICC lines in the groin area. Most commonly, they're going to be like in the AC or in the arm somewhere. So this is basically just a line inserted into their peripheral venous system, and then it's threaded, so similar to the central venous catheter where it was threaded through the subclavian down into the superior vena cava. This is going to be threaded all the way from wherever it's inserted all the way up into the superior vena cava. Okay? So there's more chance of like things going wrong with a PICC line than either of the other two, but in certain cases, some patients really need these. Let's see. What else do I want to say? Oh, something else that I would like to say about this. When you are trying to draw from a patient that has a PICC line, like that's like your first step. You still try to draw blood from them, and then if you can't, you go and get the nurse to draw from their PICC line or central or port. So when you're doing that initial blood draw or trying to draw initially, do not apply your tourniquet above the PICC line. I would honestly just go to the other arm if it were me, but if I didn't have a choice, say there was an IV on the other arm and a PICC line on that arm, I do not put a tourniquet above the PICC line. It could actually damage the line due to the pressure of the tourniquet. So try to put your tourniquet below the PICC line. So let's talk about the differences. Your central venous catheter is inserted in the neck. So if you see something sticking out of a patient's neck, like it looks almost like an IV sticking out of their neck, pretty much. However, it's not. So coming out of the neck, that's a central venous catheter. What do they all have in common? They're all being threaded into your superior vena cava, right? So the difference is where it is coming from, where that catheter is coming from. So your central venous catheter is coming from your neck or your subclavian or jugular veins. Your port is coming from right under the skin. It's going to be the only one that's not open to the environment. So it's going to require a poke every time. They're going to have a bump under the skin. These are required to be changed every so often. You're not probably... So with ports, you're going to see more patients that are outpatients that have these. And inpatients are going to be more likely to have a central venous catheter or a peripherally inserted central catheter. This is because they are open and there's a greater risk of infection, whereas a port is not open, so there's less of a risk of infection. And then your peripherally inserted central catheter or PICC line, that's going to be inserted in the peripheral venous system. It could be your femoral or your antecubital, any of the veins in your arms. And then that catheter is going to be traced up to the superior vena cava, all the way up to the superior vena cava. So those are your three different types of CVADs that you're going to see a lot. You will see these a lot. Let's talk about our steps again. So with the port, that's going to be the only one that doesn't require flushing and discard because it's not open, right? So they just stick the needle right in there, draw the blood out, and you're good to go. With your central venous catheter and your PICC line that are open and open systems, they're going to have to flush it with saline, draw back. Why do we have to draw back a discard tube? Because it's going to be contaminated with whatever they flushed it with. They could flush it with saline, they could flush it with heparin, which is an anticoagulant, as we know. So we want to make sure that we're discarding that first drawback of blood that could be contaminated with whatever they flushed it with, okay? In ports, we don't need to do that. They're closed systems. And then to figure out how much blood we need, remember, look at our tubes, calculate in our heads how much blood we're going to need based on that. I don't know if I want to say, I don't think I have anything else to say about these. I think that's it. Oh, yeah, just refresh. Never apply a tourniquet above a PICC line. Remember that. Okay. So moving on to allergies to equipment and supplies. A lot of patients do have an adhesive allergy. We use paper tape. That's the only adhesive material that we use as phlebotomists. I always ask if I'm going to use paper tape. I always say, is paper tape okay? If it's not, Coban. Coban. I prefer Coban over paper tape, but there are some situations where paper tape is more sufficient. If you're in like a trauma situation, it's kind of difficult to wrap the Coban around a patient when you're like rushing to get out of the way of the nurses and doctors that are rushing in around the patient. So paper tape can sometimes just be like a quicker motion to get it on and get out of the way. But I always usually ask if a patient is okay with paper tape, because if they have some sort of allergy, they will tell you. And a lot of times I will come in behind other phlebotomists that have used paper tape, and I will notice that it is tearing up a patient's skin. So they don't necessarily have an allergy to it, but they've had it on and off so many times in the time that they've been in the hospital that it's actually starting to rip the skin, and like you'll be able to tell if you see it. But their skin just gets really irritated from the tape, and so I will choose to put Coban on instead. I have had patients that I walk into the room, and as soon as I walk into the room, they say, I need Coban, I can't use tape. Perfect, thank you for letting me know. But if you're unsure, just ask, is paper tape okay? Or just use Coban. Although I've had one patient that has had an allergy to Coban and told me, I need tape. So I have both on my tray, and I assess the situation. Each draw I assess differently. So if they don't want a bandage, I always stand and hold pressure on the site until it stops bleeding, and then I still have them hold pressure after I leave. So I will hold pressure until it stops bleeding, and then I will say, can you hold, if you don't want a bandage, hold pressure on this for another 5 minutes. So that's usually sufficient if the patient is willing and able. Some people have allergies to betadine, chlorhexidine, so the antiseptic that we use for blood cultures. It's important to know that we do have different types of antiseptics for if patients are allergic. I don't typically carry all of them on my tray, but I do carry betadine swabs, alcohol swabs, and chlorhexidine preps. It's uncommon that a patient's going to be allergic to the alcohol swabs, but there are some. I mean, obviously, there are some patients that can be. So latex allergy, we really don't have to worry about it, because due to the increasing frequency of latex allergies by both patients and staff, I don't think many places even carry latex gloves anymore, so don't worry about that. Okay. Excessive bleeding. So you guys remember me telling you the story about how the patient that was on blood thinners left and came back 2 minutes later with blood dripping down his arm and his sleeve saturated with blood. So definitely make sure that you are holding pressure on the site until the bleeding stops before you wrap it. Do not just throw gauze on it and throw a tape or bandage or Coban wrap around it and think it's good. Not only can what I told you guys about happen, where the patient comes back with blood dripping down his arm, but also there's a much greater chance of that patient acquiring a pretty good bruise if you don't hold pressure till the blood stops. And then, like I said, if bleeding continues for longer than 5 minutes, you definitely want to notify someone. If you're in the hospital, if the patient's an inpatient, let the nurse know. If they are an outpatient, notify whatever physician ordered the tests. And and never apply a pressure bandage instead of maintaining pressure on the site. So that's pretty much what the phlebotomist did when that man came back. She just put a pressure bandage, wrapped a Coban around him real tight, and called it good. That doesn't necessarily do much for the patient, okay? Also, do not let them bend their arm up with the gauze. That's just asking for a hematoma as well. Always just keep the pressure on it. A lot of patients will try to put pressure on it themselves, like once you put the gauze on, and I usually just say, I got it, because I want to check and make sure that the bleeding is stopped. I want that to be in my control. So, okay, fainting. This will happen. I promise you, you're going to have a faint or two. A lot of times, if patients know that they're prone to fainting during venipuncture, or if they don't like needles, or you can just tell that they're very, very hesitant about the draw, immediately put them in the reclining chair. So we have, not only do we have this upright draw chairs, but we have like a reclining draw chair. If a patient seems very hesitant or very nervous, or they're clammy or pale when they come in, they tell you that they have a history of fainting during blood draws, I just immediately put them in the reclining chair, just for their safety and my own. If, however, they don't seem nervous, they seem fine, they don't tell you they have a history of fainting, you put them in the chair, and they start to faint, I'm going to tell you what to do, how to tell if they're about to faint, and so forth. This picture I do not like. It's not a great picture of what to do when a patient faints. So when a patient faints, they lose consciousness and postural tone due to insufficient blood flow to the brain. So they go limp. If you're standing next to the patient when they go limp, they could slouch or fall over the arm of the chair and hit their head. You want to stand when a patient faints. You want to be standing right in front of them. You want to hold them underneath their armpits and put your one of your legs between their two legs so that they don't slouch and slide down the chair. You are standing there holding them, and immediately call for help so that another phlebotomist or a nurse can come help you get that patient to the recliner chair. Okay, so your goal is to get them to the recliner chair, get them laying down, get their feet up, get a cold washcloth on the back of their neck, give them some time to come to, kind of thing. Once they come to, offer them juice or water, let them sit there as long as they need. If you are in the middle of a blood draw and this happens, so let me talk to you about how you'll know that a patient's about to faint. Because if you are in the process of drawing their blood, the needle is in their arm, and you can tell they're about to faint, you're going to want to immediately pull that needle out and prepare yourself for them to faint. Okay. So the patient will get really pale. They'll get clammy and sweaty almost. You can feel it on their skin. The biggest indication is they will get super pale. They might stop talking. So be alert and aware of these signs. Immediately discontinue the draw. Call for assistance. Prepare to catch them if they fall. Okay. Also be prepared for them to potentially vomit when they come to. I've had a patient that fainted on one of a previous student that was drawing. They fainted and vomited as they fainted. Hit their head on the side of the draw station. So, like I said, know the signs. Get prepared to catch the patient. Trying to think of something else. Another thing I'd like to say is if a patient is feeling faint, so you finish the draw and the patient's feeling kind of faint. Let them sit there for a little while, offer them juice, offer them water, because there have been times where a patient will, stand up, walk halfway down the hall, and then faint after the blood draw is already done. So just take your time with each blood draw, analyze their body The signs and symptoms of fainting: pale skin, clammy, sweaty skin, stop talking. That's another thing. So, like, if a patient is prone to fainting and they tell me that and I put them in the reclining chair, what I do is I try to get them telling me a story, because if you're talking, you're not going to faint. You want to keep them talking the entire draw, and just take your time with it. Okay, nausea and vomiting, like I said, this can happen. If they start to feel nauseous, like they're going to throw up, obviously discontinue the draw. Give the patient a wastebasket, or we have like little MSS bags. Apply a cold, damp washcloth to their forehead or the back of the neck. That's really all I want to say about that. I haven't had many patients vomit during a blood draw, but those are the steps that you're going to want to take if they do. Okay, so pain. While some pain should be expected during a blood draw, extreme pain might indicate like some sort of nerve involvement or something else, and the draw should be immediately terminated. So if a patient is wincing in pain, something's probably not right. The initial poke should probably be the only time that they are wincing in pain, and it shouldn't really be that bad. Although some people have lower pain tolerances than others, so just be aware of that as well. So I always usually warn the patient right before I stick the needle in. I'll say, okay, here comes a big poke. But some patients, when they come in, will ask you not to tell them, or if a patient is hesitant about the draw, I will ask them if they want me to tell them. Reflex for some people that aren't prepared for a poke is to pull back their arm, and that can pull the needle out of your arm. So it is usually best to prepare the patient unless they ask otherwise. Obviously, it says avoid, you never want to excessively probe, what we call fishing in the phlebotomy world, where you're poking around blindly, trying to find a vein. If you get into the skin, you poke into the skin, and you're not getting blood flow, and you can repalpate above the needle and feel, okay, I'm just left of the vein. I can redirect. I can pull my needle back, move my arm a little bit, and redirect the needle into the vein. Then you are welcome to redirect your needle. But you will never blindly probe or fish around. If you cannot feel where you are in association to the vein, you will not redirect your needle, because that's not redirection, that's just probing. That's what I say. If you can feel and move your needle into the vein, that's a redirection. If you are blindly probing around in the skin, that is not a redirection. Okay, so extreme pain or numbness, if they say that their hand is going numb or their arm is going numb, immediately remove the needle, get ice, and if the pain persists, document the incident, let your supervisor know. I've never heard of anyone hitting a nerve, but I know it is possible, okay? And I've had outpatients come in and tell me about nerve involvement with previous blood draws. So as long as you're following your procedures for your draw, then that shouldn't happen. But keep that in mind. Okay, petechia. I've never witnessed this myself, but basically these are tiny, non-raised red spots, and they only appear on the arm when a tourniquet's applied. This is not an indication that you're doing anything wrong. This is pretty much a condition that the patient has, or it might be familial. I don't know. But basically, it's blood escaping weak capillary walls when the capillary walls are under pressure, and this could be due to certain medications or an underlying medical condition. So if you see that, don't be alarmed. It's nothing that you're doing wrong. You don't need to discontinue your draw. Just be aware of this condition. Okay, seizures or convulsions. I have never witnessed this happen. But obviously, if a person starts seizing, immediately discontinue your draw and hold pressure over the site. But do not restrict the patient's movement. Do not put anything in their mouth. All you're going to do is try to get them on the floor so that they don't fall onto the floor, safely onto the floor, and protect them from injuring themselves. And you're going to, every single room has a call button or a pull string. You're going to push that call button, you're going to pull the string, and you're going to yell for help, okay? And first aid personnel will come in and take over from there. So your job is to pretty much call for help in a situation like this and make sure that obviously you discontinue your draw and put pressure on the site so that they're not bleeding all over. Okay. So, other procedural error risks would be, like we talked about in the first portion of this lecture, is hematoma formation and bruising. Like I said, if you start to see that vein puffing up, you blew that vein, and you are going to immediately discontinue your draw and hold pressure over the site for 2 minutes. You want to minimize that hematoma as much as possible. If it's really bad, you can offer a cold compress or an ice pack. But like I said, you definitely don't want to continue a draw if a hematoma starts forming. So I want you guys to turn to page 289, box 9-1. These are situations that can trigger hematoma to form. So if an artery is accidentally punctured, there's going to be other indications that you've punctured an artery than just a hematoma forming. If the blood is squirting into the tube, that's definitely indicative of an artery being punctured. If it's bright red, that's indicative of an artery being punctured. Other situations would be excessive or blind probing used to locate a vein. So you're just blindly poking around in there. Oh yeah, the vein's got to be in here somewhere. I'll find it. No, never an option. Not ever. If you do not apply adequate pressure following your venipuncture, so like I said, if you just wrap them up and send them on their way, make sure you're checking to make sure that the blood has stopped before putting your bandage on. If the arm is folded, to hold the gauze in place after venipuncture. So like I said, you're never going to let the patient bend their arm up to hold the gauze. You are either going to hold pressure on it or you're going to have them hold pressure on it. But they're not going to bend their arm to hold pressure on it. That's not an option either. So we're going to also talk about later in this chapter the next few things. But if the needle is only partially in the vein, blood can be leaking out through where the needle is puncturing into. If the needle is removed while the tourniquet is still on, this is a potential hematoma trigger. If the needle goes all the way through the vein, it can be leaking out. If the site is bandaged without determining that the bleeding has stopped, like I said, or if the vein is too small for the size needle that you used, or if they just have really weak vein walls and you blow their vein. Commonly in the elderly, the vein walls are quite, what's the word I'm looking for? They're not as strong as others, so they blow. Some elderly patients' veins blow a lot easier. I have had personally a few elderly patients where no matter what size needle I use, what vein I went in, it just blew. And sometimes that happens. So what I did was I collected what I could before the vein blew, and then did a finger stick for the rest of it. Because, every time I poked her, the vein would blow. So sometimes that happens if they just have really weak vein walls. Okay, so iatrogenic anemia is an anemia brought on by blood draws. So if we're drawing so much blood that they become anemic, that's what iatrogenic anemia is. This is especially important in cases of young children or infants. So life is threatened if more than 10% of blood volume is removed at once. Well, obviously, an infant or a young child has a much smaller blood volume than an adult. So it is super important to make sure, like we talked about this in class, I know, that you are keeping track of it's by weight. So I'll post the infant draw chart on Moodle along with that picture that I talked about. It goes by weight on how much you can take from the patient. So if a 3-year-old comes in and a doctor wants 17 different tests on him, and you might only be able to collect for 3 of the tests, you always want to be sure that you're not removing too much. Another thing is if you're removing blood on a regular basis, it can also lead to this. So if somebody's getting their blood drawn every single day, it can lead to this because their body isn't making blood fast enough to keep up with the amount of blood that's being removed. This is why if you're donating plasma or you donate blood, they have limitations on how often you can donate because they don't want to threaten your life by taking too much blood. Okay, we talked about inadvertent arterial puncture. Obviously, a rapidly forming hematoma will form. Blood will fill the tube quickly or squirt into the tube. What else do I want to say? Oh, something else I want to say on this slide in regards to the iatrogenic anemia. If you do draw more than 10% of blood, or somebody loses more than 10% of their blood volume, and it's to a point where life cannot be sustained, this is called exsanguination. So basically they bled out. And this can happen in infants and children if you draw too much blood. So always check that chart. I will post it. You guys can get a good indication of weight and volume of blood that you can take based on weight. Okay. We're already at an hour on this portion. I don't think we have enough to make a whole other video for the next one, but I will stop this and finish this lecture as well as chapter 10 in the next video because I know we're already at an hour. So, okay, stay tuned.